Thank you, organizers, for inviting us for this talk, short talk. Me and Dr. Gohar is going to cover up the precision oncology. Can you put our talk, please? Often a question comes, actually, what do we invent in this country? If we look into the precision oncology, and I'm sure that Dr. Om Sri will also say that probably we import even water that we use in this country for genomics. So I'm going to present about a story of a group of scientists who are here to actually revolutionize precision oncology in the format of liquid biopsy. Let that be a circulating tumor cells, or let that be a precision oncology. My sincere thanks goes to again Tata Memorial Hospital, without mentioning Dr. Pankaj and Dr. Kumar, who actually leads clinical practices in this country, often dare to actually mention some of our breakthroughs in form of circulating tumor cells that what we have seen in this country on about 3,000 patients, which includes clinical trial and real patients scenario. So we are first in class indigenously developed technology, and this is India's first medical device that has been approved by Drug Controller General of India. And it takes about 8 years of a time, 100 crores rupees, for a scientist and clinicians to work together and bring that three mottos of World Health Organization to make this kind of technologies accessible, affordable, and available. And that's what is the principle that what we do it. Cancer patient monitoring and blood tests are probably going to be very important. I'm not going to say whether circulating tumor cells is going to be a hallmark of a disease relapse, and are we in a prime time. That depends upon to the clinicians, especially the young generations, to look into it. Who we are a company which actually file patents and publications. We started our journey with public fundings in 2013 from DBT. And in 2023, I'm very glad that we submitted about 12 ASCO abstracts day before yesterday, while we are balancing our life and actually wife at home in actually maintaining, the science at the pool. So I feel very humble and privileged that without the oncologist's help, this would not be actually possible. While we always differentiate primary and metastatic cancers, we know that, how bad is India's 5-year survival rates over to the developed countries. And we know that about 10% of the patients' mortality is in primary cancers, where 90% of the patients transform from early stage to the metastasis. Why our technology is superior? Not in the terms of its sensitivity and specificity and accuracy that we have published in Triple with Dr. Kumar Prabhash and Dr. Pankaj Chaturvedi, but in a positive time, I must mention designing multiple components, having an antibody affinity-based system with a functionality creates a great specificity and efficiency. The cells that what we capture are on fluorescence immunostaining assay on using a cytokeratin as a biomarker and CD45 as a negative marker. And in addition, when there is an issue with the tissue, can we do a PDL1 expression on single circulating tumor cells? We present this data, EACR annual conference. I think this has been accepted abstract. We have recently about 136 patients, and we found in 58% of a patient actually showed the positive CTC numbers, while in this 58%, 81% carried positive PDL1 expression. In the interest of time, I would not talk about what is the PDL1 role in immuno-oncology. But our own contribution in this country in phenotypes and genotypes, mentioning about a circulating tumor cells in overall survival of cancer patients, especially in head and neck squamous cell carcinoma. If there were more than 13 circulating tumor cells, the mean and median survival was about 19 months. When the patients had lower number, they survived for longer time. And that's world's largest head and neck squamous carcinoma study that actually we presented. Very pertinent question. Dr. Chirantan is here. I think he will agree that our CTC surrogate markers for a cancer require cancer recurrence and relapse. That's a key question. Can CTCs be used as a predictive marker for residual disease? Definitely yes. Can CTCs be used as a preemptively to radiological evaluation after first line of a therapy? I'm going to present few cases. Can CTC be used as a monitor to response to the treatments? Yes. Can trends in CTC count help modify treatment dosage metastatic disease? after failure of a first line? Definitely yes. Can circulating tumor cells reveal information on tumor heterogeneity and resistance to therapy? The era is actually moving towards single cell genomics. And that's what is our latest patent on single cell DNA amplification and comprehensive genomic panel determinations. Case number 1, 68-year-old male was diagnosed with squamous cell carcinoma of a left lung. On the right panel, if you see, this is what is the baseline PET image, and on the left-hand side is actually a follow-up post-treatment PET. And what we found in this patient, that follow-up CTC test revealed about 1 CTC per ml, indicating persistence of a cellular disease. That's a minimal residual disease. And it was followed with an HRCT, and there were new primary lesions, fibrosed and shrunken, were observed, as shown in the pictures. Case number 2, 18 January 2018, the patient has a triple positive breast cancer with post-surgery, post-chemo, post-radiation, and on a maintenance therapy with dual HER2 blockade for 4 years, no detectable lesions on PET scan. And circulating tumor cells, OncoDiscover, we could find 4 tumor cells in 1.5 ml, of which 2 CTCs had positive PD-L1. And then multiple FDG enhancing lesions were detected in liver at follow-up after this. This is what is a minimal residual disease in a real clinical setup. I would like to acknowledge Dr. Nirmal Rao's recent tweet that female 65 years, PS0, CA rectum. I think the patient was completely disease-free by absence of a PET scan. For some reason, he sends a blood sample to us. We found 2 CTCs in 1.5 ml, and the debate started where these actually cells come from. The MRI in the liver showed 4 lesions. The patient went to SIRT treatment, and until today, the patient does not carry now any circulating tumor cells. So I'm trying to talk about cancer's 3 problem, that there is a relapse, there is a minimal residual disease, and there is a dormancy, and the circulating tumor cells can actually account this very well. And this is the second last slide, that disease monitoring with circulating tumor cells when your decisions on female 80 years old who wanted to refuse the surgery with simple oral metronomic chemotherapy, 3,000 rupees per month, CTC number in 40 to 45 days went down from 3 to 0. And remember that the therapy or the decision would have been actually very, very bad in this case if the treatment and the response was not there. This was a clinical study that we did with the Tata Memorial Hospital. Dr. Gore.
Thank you so much for giving us this opportunity. Earlier speakers made my job easier. I know most of us were talking about liquid biopsy. So this slide shows the cancer burden, in 2008 and in 2030, estimated burden is almost double. So what we'll do, and that's where the precision medicine is going to play an important role, and molecular profiling, incorporation of these in routine practice is going to change the global cancer care. We know that technology is rapidly evolving, cost has come down, and we have to prove the better and improved outcome. How can we do? That's the possible only way is to profile every cancer and possibly use circulating tumor DNA. And we know now circulating tumor DNA can be used for diagnosis, treatment response, acute resistance. Most importantly, how can we use it for minimal residual disease? This is, a lot of data is published over there. And one of that I have picked up, shown that post-surgery, how can we monitor the patients and see the difference of, patients who could recur and who could actually benefit without any treatment. So I was looking into the literature, in last year, 2022, there are more than 400 abstracts using terminology of ctDNA. And when you look back in, 2012, a decade ago, there were only 10 abstracts. That shows that, how the technology is evolving and, importance of ctDNA. And often we get this question, do we get this, can we get ctDNA from different types of cancers like brain cancers, glioma? This slide shows that the percentage of ctDNA, what you see, it's almost in all cancers, including glioma, where we can have the ctDNA, though it's a very minimal amount of DNA we get it. Now, technology has improved that, we can do this NGS on as low as 1 nanogram of, ctDNA to do the NGS analysis. So we were previously using protein biomarkers for monitoring, and we know that, the half-life of them are, weeks or, months together. And when we look at the ctDNA, the half-life is minutes or hardly in hours. That gives us the ability to, monitor quickly patients who could, whether they respond to treatment or there need to be a switch in the treatment. So when we talk about cell-free DNA, cell-free DNA is the total DNA which is studied into the body from the aging cells, including, in cancer patients, the DNA coming from the tumor, and which is very small amount. That's why the newest technologies which has come up plays an important role, that you have the ability to do the NGS on small amount of ctDNA. So where we can use it, we know that tumor heterogeneity is the biggest problem. And within the tumor, primary tumor, you have the heterogeneity. And then when it goes metastasis, then we have intermetastatic heterogeneity. That's where this liquid biopsy, ctDNA-based liquid biopsy plays an important role to define that. So for example, there was a 53-year-old ovarian cancer patient. For earlier NGS tests has suggested 2 gene mutation ERCC, 2 and TP53, and patient was treated, and it was an MSI high by earlier NGS. And then patient was treated with immune therapy, progressed in 4 months. And then, we did this patient again, both tissue as well as liquid. In the tissue, we saw that those 2 mutations, but in the liquid, what we saw is very interestingly, there was a BRCA2 mutation suggesting this patient can benefit with PARP inhibitors. At the same time, we found STK11 mutation, which explains the reason that why this patient has progressed on immunotherapy. That's where it becomes very important. It's not only to define that what treatment can work. We need to find what treatment cannot work. So then another problem is we know that tumor is evolving very fast, and we need to understand that how can we see that the evolution has taken place and how that impacts the current treatment. So for example, there was another breast cancer patient, when we took both tissue and liquid, and in tissue, we found ESR1 mutation and JAK2 mutation at the allelic fraction of 1 and 15% respectively. When we looked at in the ctDNA, and then both mutations were identified. However, the allelic fraction, the burden was almost 3-fold higher, explaining that those clones having ESR1 JAK2 mutation has grown further. At the same time, we found here other mutation like PIK3CA, MSH26, and CCND2, explaining that either this tumor has evolved or because of the tumor heterogeneity, that's what we have missed in from the tissue, explaining that superiority of liquid biopsy if you have the latest technology. When we looked at this particular patient, that the difference between the tissue biopsy and liquid biopsy was approximately 5 months, explaining that if you have older tissue, you should not go for NGS testing. It's not giving information, and you miss most of the information. And this also suggests that we are in the era of that we have to go for longitudinal monitoring testing to actually understand the minimal residual diseases. Another question, Dr. Omshiri has explained, which panel, which gene, which testing. One of them I would like to highlight here, whether small gene, single gene, or comprehensive gene testing. BRCA, every oncologists go for mostly ovarian and breast cancer testing. They go for BRCA1, BRCA2 testing, and to see that, if patient could benefit with PARP inhibitors, particularly to define HRD phenotype. Now we know HRD genotype is not just BRCA1, BRCA2. We have other HRR genes. We have, loss of heterozygosity, loss of transition, telomeric allele imbalance, epigenetic markers, and even unknown factors. We looked into about 177 ovarian cancer patients, and where we found BRCA1, BRCA2 only in 17% of patients. When we expanded to other HRR genes, it was 26%. And when we went to comprehensive way of looking at LOH, LST, and TAI, including our HRR genes, we found 54% patients are actually positive, could benefit with PARP inhibitors, suggesting that you miss two out of 3 patients if you do BRCA1, BRCA2 testing. So this explains that there was one case which was ovarian cancer case, a progression with metastasis, BRCA1, BRCA2 negative. And when we did testing, comprehensive testing, and we found KRAS mutation, in addition to this loss of heterozygous and HRD based on the comprehensive profiling, and was high, suggesting the patient could benefit with PARP inhibitors. When we looked into the literature, we saw that there are the literature patients who are BRCA1, BRCA2 negative and have high LOH score benefited with PARP inhibitors. To summarize that, comprehensive profiling can help actually identify the driver mutations, capture the tumoral and metastatic heterogeneity, and gives the rationale for combination therapy or sequential therapy. And using these ctDNA approach to assess the increase or decrease in ctDNA level, which could help us to actually monitor the disease. And what is going to change now is that assessing the ctDNA based analysis, it can help us to actually save the time, because half-life of ctDNA is very short, and possibly within 2 weeks or within 4 weeks, we know that whether the drug is working, and our drug is not working, we may need to change the therapy. Thank you so much.